So how we have planned this session is I'm going to give some information about pain and what are the factors that may be associated with pain. And after that, we'll talk about Aray's experience with transplant and related to pain related to sickle cell disease. So pain, as everyone knows in this audience, is the most common complication of sickle cell disease. And there are multiple things that happen when a person experiences pain. So there's morbidity, patients get admitted in the hospital. It is associated with poor quality of life. And as we heard in the earlier session, it can really impact what a person can do when they are having pain. Next slide, please. So pain starts very early, and many of our individuals who are listening in today, they may remember or they may have seen that pain starts very early as 6 months of age, as you can see in this picture on the left side, where the baby's hand is swollen and he's experiencing acute pain in that area. As the patients get older, although they still come to the hospital for management of acute pain, we know when we see our patients for severe episodes of pain, it's just the tip of the iceberg. Many of our patients may not come to the emergency department or hospital, but they continue to experience pain as shown here. Next slide, please. So other thing I'm hoping that to also educate audience a little bit, because those are important factors when we talk about pain before transplant and after transplant. So chronic pain is a major problem for sickle cell disease. And the actual definition of chronic pain is if someone is having pain more than 50% of the days in past 3 to 6 months, they are called chronic pain. And the chronic pain pathways, like why someone experiences chronic pain, are very different than when someone experiences acute pain. Next slide, please. You can keep going. So this slide shows some of the reasons why someone may have acute pain and on the background of chronic pain. So someone on the left side, as you see the X-ray of the hip joint, someone may have the avascular necrosis of hip, and that can cause chronic pain. Sometimes they may have gallstone, as shown in the ultrasound up there, or the leg ulcer on the picture on the right side. Or sometimes we have this pain, which really is very difficult to explain. We have done the hip imaging, we have done the other tests and things like that, but cannot really pinpoint what exactly is causing pain. And this kind of pain, the image of the person is shown here, is generally multifocal. So there are many sites that have pain, and it's constant, it's impacting them, patients, more than 50% of the days. Next slide, please. So what happens after a person gets bone marrow transplant? It's very clear that, and as you heard earlier, most individuals, if the transplant is successful, their pain goes away. They don't have pain, and if they were taking opioid for controlling their pain or other pain medication, the use of pain medications go down. Next slide, please. But what we have seen in our experience, there is a small group of individuals who may have gone through a successful transplant, but they continue to experience pain. And the pain sometimes is so severe that they continue to need the pain medications, including stronger ones, such as opioid, after they have been cured of their sickle cell disease. Next slide, please. So we wanted to see what are the factors that may make a person susceptible to have pain after successful transplant. So this data is from that I'm going to share with you is from NIH, and Dr. Fitzhugh, who's on the panel list here, came from the patients who were treated at NIH and they were successfully cured. So we looked at what are their lab factors, how is their hemoglobin, what are different things in their labs that may be different and can help us identify patients who may be at higher risk for continuing to have pain after successful transplant. These patients also reported what we call as promise measures. So promise measures are patient-reported outcomes. So patients are They will tell us how's their pain intensity, what's the impact of their pain, what is the anxiety level, how's their sleep, and different things that you see on slide. So these were reported by patients and they are called promise measures because they are patient reported. Next slide, please. So what we saw that, patients who were successfully transplanted, pain admission, as you can see highlighted here, improved significantly. So pre-transplant, if they were having, range of admission was 0 to 24 after transplant, and this is cumulative data, not just one person. And after transplant, they reduced from 0 to 3 per year. So this was significant reduction. Opioid use at the second highlighted point below, you can see that also went down. So short-acting opioids such as oxycodone, that use had improved significantly, and so was the long-acting like MS-Contin. That use had gone down significantly, meaning the pain levels had really improved. Next slide, please. But as you can see here, there was a group of individuals who, this is 1 year after their successful transplant, but there was few patients who continued to experience pain, and pain was so severe that they needed opioid to treat their pain. Next slide, please. So we wanted to see what are the risk factors and who are those individuals who continue to have pain, and what were their factors before the transplant that may have made them susceptible for pain and opioid use after the transplant. Next slide, please. So what we saw, the definition I gave you chronic pain earlier, there's scientific way of defining chronic pain, but we are not going to go into that. But as you can see here, the red circles show individuals who had chronic pain. They were at higher risk for continue to experience pain after successful transplant, and also opioid use. And patients on the left box that is not highlighted, patients who had just the acute pain, they were totally cured and they had no pain. Next slide. So we wanted to see, was there something different in their labs prior to transplant that may help us identify these individuals? So as you can see here, there were really no differences. So labs prior to transplant, there were no differences when we looked at the patients who had no pain and opioid use after transplant, or pain and opioid use after transplant. So there were no differences between these two groups. Next slide, please. If you can click one more. Keep doing. Thank you. Keep clicking. So then we wanted to see what are the other. So we saw the labs were not different prior to transplant. So were there certain differences between patients who continued to have pain and patients who did not have pain? So here are highlighted some of those in the red script as you see on the right side. So patients who were older, they were at higher risk to have pain. Female gender was more common in our group. They had more pain admissions prior to transplant, more opioid use, more comorbidities, and also higher pain. So really, if you think about this, they have much higher burden of pain prior to transplant going into transplant. Next slide, please. So we also, as I mentioned, we also had asked about some of the psychological factor as promise measures, so as reported by the patients. So here you can see patients who had higher scores, they were more likely to have anxiety, depression, more fatigue, more sleep disturbances, and pain, and higher impact of pain on their daily activity. These were the individuals who were at higher risk to continue to have pain and opioid use after the transplant. Next slide, please. So what can we take out from this information? So we saw that factors, those were associated with continued pain and opioid use after transplant, these were such. Pre-transplant pain experience. So if person has higher burden of pain prior to transplant, they are at higher risk. If an individual had chronic pain, they were at higher risk for having this problem. Older age, higher doses of opioid. So some, especially like long-acting opioid, they were at higher risk for continued pain, and also psychological profile. So if a person had more like anxiety, depression, or some of these other factors listed here, they were at higher risk for continued pain. Next slide, please. So why does that happen? And it's a complicated slide, but I want to inform you why this may be happening. So we know if someone has chronic pain or higher burden of pain, So you experience pain, but in long run, it can impact our brain, the pathways in our brain that help us feel pain. So there are certain changes in the brain that happens, and it has happened over time. So from young age to as you become teenager or adult, the pain is constantly happening, and it has impact on the brain, and that can change the pathways that may lead to persistent pain. The important thing is that it takes many years for a person to reach to this state, and it also may take longer time for them to come back where they may have started. And this phenomenon in science is called neuroplasticity, just like how the changes in the brain occur, and this process is neuroplasticity. So that we believe is very important, how a person is going to respond after successful transplant as it relates to pain. Next slide, please. So what can we do to improve pain outcomes? Because obviously when our patients go through transplant, we want them to feel better, and hopefully pain also goes away. So what can we do prior to transplant? And these are some of the strategies we hope everyone can do that. So first is better control of sickle cell disease, and such as disease modifying therapy. So the sickle cell disease is in control, and really the neuroplastic changes I showed you, hopefully that can prevent from happening. So the goal would be to reduce pain burden prior to transplant by multiple things. So it could be drug, it could be physical therapy, it could be psychology, counseling, and things like that. Opioids, although they are our friends, they also cause damage to brain and certain other organs. So it's important to minimize the use of opioid if possible. And as I mentioned, management of psychological comorbidities with counseling, medication, and other things is very important.